I hope everyone is back from the break. We'll be continuing the sessions. I would like to now call upon Dr. Valessa Joseph of Southeastern University, USA, to deliver her keynote talk on the title, Communication Challenges in Nursing Education and Healthcare Effects from COVID-19.
All right, just had to unmute my self here. Hello and welcome everyone. Good morning. My name is Dr. Valessa Joseph, and I currently work in the primary care setting, and I am also an assistant professor at Southeastern University, and I teach in the graduate program and teach current nurse practitioners. And so today I would like to speak to you on the topic of communication. Just want to make sure that you guys are able to view my screen. Are you able to view my screen?
Yeah, we can see it.
Okay. All right, so today I want to talk to you on communication challenges in relation to health effects from COVID-19. We know that communication is an important paradigm in both the acute and the primary care setting, as poor communication in the healthcare environment has negative implications on our patient satisfaction, our patients' compliance, and their overall health. Communication itself influences collaboration amongst the healthcare provider and the patient's experience. There is a strong correlation between healthcare communication and a patient's ability to follow recommendations, self-management of chronic illnesses, and demonstration of following health promotion strategies. And so despite prior challenges with communication that our healthcare system currently had, the COVID-19 pandemic has brought upon unprecedented barriers to communication and increasing communication challenges in our healthcare system. So with patients currently being in isolation, with current lack of necessary resources and our nurses being burnt out, and a higher level of stress, this has caused even more challenges to a already burdened system and complicated system with communication. And so many healthcare teams are looking for ways to navigate through these current challenges during this time of crisis. And this highly includes having and looking for a means of effective communication amongst patients and staff. So, however, there is no known study that has described communication in nursing practice during the COVID-19. So therefore, the purpose of this project was to conduct and look at a primary examination of communication experiences with these patients and their satisfaction and the current challenges staff is going through during the COVID-19 pandemic in the primary care setting. So the primary healthcare setting in which this project was implemented was having and was characterized by problems where there were unclear roles and responsibilities, a lack of a standard protocol, and no direction on how to communicate with these COVID-19 patients. And so a quality improvement study was done and conducted in the primary care setting using different stakeholders, which included healthcare providers and medical staff members in the primary care setting. So we used a sample of 48 patients for collection of data on their satisfaction with the current communication of the staff. A pre-test and a post-CAP survey was administered among these patients to determine effective communication among the staff members and the patients. A data analysis occurred using descriptive and inferential statistics to establish the impact of using the aided framework on provider-patient communication and patient satisfaction during this pandemic. Ethical considerations were used for patients, participants, and confidentiality of the data. And so the purpose was looking at, can we improve patient satisfaction, and can we help with the current communication challenges by implementing the aided framework in the primary care setting, which is acknowledge, introduce, duration, explanation, and thank you. So our Pico question: among providers and medical staff in family practice, does the implementation of the aided framework improve communication and patient satisfaction with the COVID-19 patients compared to the current practice? So acknowledge, is the individual provider present during the encounter? Introduce, does the provider introduce themselves, give the patient information to their identification? Duration, does the provider provide with the patient the time frame for the encounter? Explanation, does the provider do a good job at explaining what it is that they're going to do with the patient, or what is the procedure going to be and the time frame? And then ending with a thank you. The theoretical framework that was used is the human systems model. And this model is based on a general systems theory that reflects the nature of the living organism and their interaction with the environment. Human systems model was used to identify stressors and interpersonal factors between the providers and the patients in the clinical setting that might be affecting them, and the correlation between the patient's perception of their environment being affected by these stressors, and how that will determine the overall satisfaction of the patient. So the significance and methodology used is a non-probability convenience sample was used to recruit the patients from the suburban clinic that is down here in South Florida. And so a total of 48 participants were included. And the inclusion criteria consisted of an individual having to be a resident in South Florida, being positive for COVID-19, above the age of 18, and the ability to read and write in English. And of the 48 that completed the survey prior to implementation of the aided intervention tool, 29 of the completed assessments were done after the intervention. Several questionnaires had to be dropped, and that was a limitation due to missing data, so resulting in a sample size of 38. And so the aim of the project was to evaluate the impact of the aided framework in improving communication challenges with specifically COVID-19 patients and their satisfaction in the primary care setting. So in order to attain this, our objectives really were looking at, one, determining the effects of the aided framework on the staff and patient communication in the primary care setting. And we were able to do that by evaluating the CAP survey. Our second objective was to determine the effects of the aided framework on the provider and patient communication in the primary care setting. And lastly, we aim to evaluate the effect of the aided framework on the patient's satisfaction. So again, the project took place in internal medicine office, and we implemented the aided framework with all of the patient visits, and weekly huddles were done with staff to teach them how to use the framework, to ask questions, allow an open forum for discussion and feedback. So we use the consumer assessment of healthcare providers survey as a pre and a post test. And this was administered to the patients initially to assess what their current satisfaction of how the staff was communicating was done. And then we implemented the aided framework by teaching the staff members, teaching the stakeholders how to use the aided framework to communicate. And then a post CAP survey was administered to the same patients. And so some of the data collection from the CAP survey, some of the questions we asked were, did the individual meet with the staff, how they implemented the aided, the time frame that they were in with the patients, Then we collected the data from the pre and the post. So a formative assessment were performed by completing the CAPS pre-test survey prior to the implementation of the aided framework. Summative evaluations were done at the beginning and the end of the project to determine the project if it met the desired outcomes. The CAPS surveys were used to evaluate the intervention success in increasing communication with COVID-19 patients. There are about 15 questions on the CAPS survey, and the individual had to score from 0 to 10. And then the completion time was about 10 to 15 minutes with the survey. And so the questionnaire that was used was the CAPS survey. And then the analysis method, we used the independent t-test for the 2 sample groups of participants. So the descriptive statistics were generated to look for any type of violations of the assumptions of the t-test, any type of skewness or kurtosis. And then the inferential statistics was done given that the project collected pre and post intervention data for 2 different groups. So an independent sample t-test was the appropriate data analysis technique to use. And then the CAPS survey had 4 subscales. And those questions looked at if the individual was able to get the necessary care that they needed, did they get the care in a timely manner, and how well did the doctors and the staff communicate with them? And then lastly, what was their overall satisfaction? And so the results showed that the statistics demonstrated an increase in patient satisfaction once implementation of the aided framework took place, and inferential statistics were made at 5% level of significance. The independent t-test results indicated that patients rated their access to care, their speed of care that they receive, the communication between the staff and the doctors were higher following use of the aided intervention. Now, the implications for practice. So the project let us know that effective staff and patient communication does improve patient satisfaction. And this is a key metric in producing quality care to our patients. That use and the adoption of the aided framework improves provider-patient communication, thereby leading to enhanced quality of care and patient satisfaction levels and patient satisfaction scores. And then it also lets us know that this can be implemented, the aided framework, to teach providers as well as patient access to medical care, that by providing nursing education and training, it ensures translation of knowledge for delivery of evidence-based practice, that adopting the aided framework improved patient and provider communication. It enhanced the quality of care that the patients received. It increased patient satisfaction scores. It also showed that leaders played a significant role in being change managements by providing support to their providers and medical staff, by administering these materials that contributed to the improvement in the knowledge of healthcare, and that this project can be applied to further research and in other venues, such as in nursing education with nursing clinical students, as well as a means to overall improve our customer experience, our patient experience with these patients with COVID-19 to avoid poor ratings. So in conclusion, during these challenging times with communication, the project proved to show that the aided framework can be used to improve communication with the provider patient, with the staff patient, with the nursing clinical students, as well as overall improved clinical practice outcomes, and helping to establish a current standard protocol for primary care settings that do not currently have a protocol. Thank you for your time. I'll take questions at this time.
Thank you, Ms. Valessa. The floor is now open for any questions that they might have. Does anyone have any questions? I don't think there are any questions. I think the presentation was very clear and hence there are no questions. Thank you, thank you, Ms. Valessa. I would like to now hand it over to Ms. Annette Van Ginkel to continue for the rest of the day.
Good afternoon. I know that some of you are still in the morning, but we are very, very near in going to evening by us. Yes, I must say with Valessa's presentation, it helps to talk to our patients. It helps to, even if you can't speak their language, there is a way to communicate to them. So it's important that we do this, and it's very interesting and also good for us also to do this type of study and see how satisfied our patients are. Because this is normally a problem. Our patients need to be satisfied in what we are doing for them to be compliant and do whatever we want them to do. But now I call upon Joyce Akwe from Emory University School of Medicine in USA to deliver a talk on title, Cardiac Arrest During the Pandemic. Are you with us, Joyce?
I am right here, and I'm trying to share my screen right now. Let me see if I can do that. Okay. I hope this is the right one. Share. All right. Are you there?
That looks like the one. Yes, we are. And we can see your screen and we can hear you.
All right. I'm trying to see if I can swap this screen and bring this one over here. But all right, never mind. This is going to be a little bit. So for the interest of time, I'm just going to start. I'm going to talk about codes during during COVID-19. And by codes, I mean cardiac arrest, in-hospital cardiac arrest in patients who have COVID-19 or patients who are under investigation for COVID-19. So the objective of this presentation is for us to learn strategies to reduce exposure to COVID-19 during a code or cardiac arrest in patients who have COVID-19 or patients under investigation for COVID-19, to reduce cross-contamination. And then our third objective is to prioritize oxygenation and ventilation strategies with lower risk of aerosolization. So why do we do this? So the background is this, with this evolving COVID-19 situation, we think we're trying to still have it under control. I don't think we understand this fully. And it's just created a lot of challenges on how to manage codes. There's the transmission of COVID-19 is very high. And we do have this, we have existing American Heart Association guidelines for the, to address CPR, but not in the setting of COVID-19. We don't have anything in the setting of COVID-19. And so again, American Heart Association quickly created some guidance on what we could do in patients with COVID-19. And this is just guidance because it's based on expert opinion. It's not totally based on any research studies, because obviously, as we all know, with the pandemic, we did not have the time to study and say, this is the exact right thing to do. And one of the things that this guidance does clearly state is that we should adapt the guidance locally based on current disease burden in our facilities and also based on the resources that we have. So the goals of this presentation or project was to reduce our exposure to COVID-19, again, prioritize our ventilation and oxygenation strategies which lower aerosolization, and then consider if resuscitation is appropriate in these patients. So once you have patients in the hospital, especially in this era, and most of our hospitals in the United States do recommend this, but in this era of COVID, you want to make sure that you clearly address advanced directives and the goals of care for these patients. You monitor for any clinical deterioration, and in order to make sure that you intubate these patients in a timely manner. You don't want to intubate these patients when in an emergency situation, because there you're very liable to make mistakes that could expose the rescuers to COVID-19. And just as we said, if the patient is at risk of any cardiac arrest, other than making sure that you intubate in a timely manner, you want to proactively move these patients into a negative pressure room to minimize any risk of exposures. So again, we want to make sure that we don our PPEs before entering the scene of a cardiac arrest. You limit the personnel that are in the room. You clearly define the roles and responsibilities of each of the team members, and also where they should position themselves during a code, as compared to that is the bedside positioning, as when there is if the patient should go into a cardiac arrest. And then one thing that came out, and which is new, is that they did clearly state that we can use mechanical chest compression devices in adults and adolescents who meet the criteria for those chest compression devices to be used. And before any provider gets to the scene of of this cardiac arrest in a patient with COVID-19 or a patient suspected to have COVID-19, so PUIs, patients under investigation, they need to clearly know that this patient is a patient under investigation or patients with COVID, so that they should be ready, they should don themselves, they should don on their PPEs appropriately. So let me see if this is going to work now. Okay, so this is a situation, this is a complete ideal situation which you would have for a code. And let's watch this. Okay, for the interest of time, I'm going to pause this. What I wanted to show with this video is that, when people are prepared for codes and everything, they run in, they get everything rolling. But I don't know in your hospitals, but in several hospitals which I know and have worked at, that is not the reality. This is what actually happens in real life. So, all right. Yeah, so again, as you guys could see, I hope you could hear me. Could you hear the video? Yeah. Okay, thank you. So again, during our codes, we all know that codes are super disorganized and are costly in both terms of mortality and morbidity. Once a code is disorganized, it is slow and the outcome is usually poorer than a code that is well organized. And the success in codes has relied especially on the high quality of chest compressions and defibrillators. And again, everything being done in a time in defibrillation. So once you have high quality of CPR and defibrillation in a timely manner, those are some of the few things that have really been shown to increase the quality of a code. And again, disorganized codes with once we have organized codes with designated roles and responsibilities can help us reduce the time to medical intervention and improve closed loop communication and improve effective team interaction. So again, one of our main objectives, as we said, was to reduce exposure to PPE and exposure to COVID-19. And how do we do this? We do this by donning the PPE before entering the patient's room or scene. And again, just donning the PPEs, we all now, I think it's clearer what PPE should be done before getting into a patient who has COVID or suspected of COVID room. And again, it's very important that we follow the guidelines, and we must wear a face mask before we get even close to the area where we have a cardiac arrest in patients with COVID-19. You want to reduce the personnel in the room. And prior to COVID-19, we used to have about 13 to 16 team members in our code team. But again, with COVID-19, we had to clearly reduce this number of people during our codes. And the codes were usually more chaotic. And again, this is for our setting where we have 2 residency programs in the same hospital. And once there is a code, residents from both programs have to be part of the code team. And so it was a little bit more chaotic. But with COVID-19, we had to kind of like really go deep and make sure that we have just the appropriate number of people and reduce any risk of exposure to the rescuers. So we divided our code team. We had just about 4 to 5 people in the room, and then outside of the room we had 4 to 5 more people. But inside of the room, we had a code team leader. We had a recorder who would record all the information and read back to the code leader. We had a primary nurse. We had an intensive care unit nurse who was actually the one preparing the medications. In our hospital, we don't have pharmacists. Ideally, we wanted to ideally the person preparing the medications should have been a pharmacist. And then we had chest compressors. And the chest compressors have been replaced by chest compression devices, and which is one of the new things that was added to the American Heart Association algorithm for patients who go into cardiac arrest. And then outside of the room, we had like the unit nurse leader, we had the code assistants. The code assistants are people who run around and get anything that we need during a code if the things are not already in the code card. And we kept the code card outside of the room to reduce contamination. So the mechanical chest compression devices, which again were recently added to the American Heart Association to be used for patients with COVID-19, perform chest compressions at the recommended rate of 100 to 120. The depths as recommended 2.1 to 2.4 centimeters. These chest compression devices help us to reduce the personnel in the room and also to reduce exposure to COVID-19. And this is an example of the chest compression devices. Let me just show how this works. Yeah. So even during transportation, these chest compression devices can be used. Mm-hmm. 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 Okay. Mm-hmm. All right. I'm going to stop here. And we have, so that I can be able to show the other type of chest compression device, equal opportunity. I don't want to, I have no conflict of interest. So I want to make sure that I show the devices that are in the market at this time. So this is a second chest compression device, and you can see how this works. Oh, okay, I have an interruption. I'm not exactly sure why. I don't know if you're able to at least see how the device works. And let me see here. I'll give it. Okay, here we go. So as you can see, it compresses at the depths of 2.1 the depth, which is supposed to be 2.1 to 2.4 centimeters, and at the rate, the heart rate, which is supposed to be 100 to 120 compressions per minute. So, and with these devices, you can transport the patients, you can do anything. And again, it reduces exposure to COVID-19. So, all right, I'm going to move on for the interest of time. Okay, all right. So, the next thing we want to do is want to make sure that every person who is at the scene of the code does know exactly what their expectations are, what are they supposed to do. And so we have to clearly define the roles, responsibilities of each member. And not only, we have to also clearly define what positions they have to position themselves at in order to perform the responsibilities they are supposed to perform to the best. So we do have here, we have this is our patient right here. We have the chest compression, we have chest compressors here, which if we have chest compression devices, then this person is going to go away. We have an ICU nurse who administers medication. We have the code leader here who sees the monitor and is able to run the code and give the next instructions. The recorder who is here to remind the code leader of how many minutes have gone by since they had the last medications and stuff like that. We have the primary nurse who has our computers on wheels and is able to give any clinical information about this patient when the code is going on. And then outside of the room, we have the code card, which the ICU, again, a medication nurse will prepare the medications and send it into the room to the primary nurse to administer or to the ICU nurse to administer. We have a unit nurse leader who is just there to oversee and make sure that everything is running as appropriate. And if anything is needed, this unit nurse leader will ask the code assistants to run around and get what is needed as soon as possible. Most of our code cards and our code environment do have everything we need, but we want to be 100% sure that should, in case we need something, we are not short of people to run around and get that done. So the last thing we want to take into consideration, again, with regards to reducing exposure to COVID-19, is communicating the status of COVID-19 to every single provider who will be getting to the scene of the code to run a code. So, and there are different ways to do this. There are some hospitals do pre-announced tactically that this is someone that there's a code. In our hospital, we call it code 99. It will be like code 99 to a certain location. And if we all know what the COVID locations are, we know where the COVID unit is. So if you hear code 99 to 9C, 120 something, our 9th floor is where we have all our COVID units. You immediately know that that is a COVID patient or a patient under investigation. So you get ready, right? Some places do add a code, an added code. Some say code 99C. And that just tells you that this patient who is coding is most likely someone with COVID-19 or under investigation. And then some places, they just have a direct communication to their paging system or to the phone, which tells you clearly that this is someone who has COVID-19. And so when this is the situation, you have to done appropriately before even getting to the scene. So our second goal was to prioritize oxygenation and ventilation strategies with lower aerosolization risks. So the first thing to prioritize oxygenation and ventilation strategies with lower aerosolization risk is to make sure that you use a HEPA filter, that is high efficiency particulate air filter, which ideally should be able to filter particles, even viral particles, if this is available. If it is not available, you have to, well, if it is available, you have to use that for all ventilation. Even patients who have already been, who are already on a vent, you still have to make sure that they have the HEPA filter. You want to intubate these patients very early in a timely manner. and you want to intubate with a curved tube if possible, and then you connect to a ventilator as soon as it's available. So intubate the patients as early as possible. Don't get the patient to a state where they already are super compromised, and you have to be you have to do it so hurriedly that again, you're risking exposure of other people. This is a situation where you want to make sure that you use the person who is going to intubate is a person who has the most experience, a person who will most likely be successful at first pass of intubation. You don't want to use a trainee in this situation. And I talk of trainees because our hospital does have, again, several trainees. But once there is a code in a patient with COVID, most of the times we, the attendings, are the ones who go ahead and intubate the patient. Once you're intubating a patient with COVID-19 or a patient under investigation, you have to pause the compressions in order to reduce aerosolization. You cannot intubate these patients while compression is going on. At times that happens in patients who are not, who do not have COVID-19 and who are not under investigation. You can intubate them while compression is going on, but in COVID patients, it's absolutely prohibited for you to do that in order to reduce exposures. Consider using a video laryngoscope if you have it available in order to intubate these patients. Again, that helps to get the intubation right at the first time and reduce aerosolization and of course exposures. Before intubation, you want to make sure that you use a mask device with a HEPA filter, and it has to be very tightly attached. You don't want to do something which is not attached, and during compression you have aerosolization. The seal has to really be very tight. And then consider using a non-rebreathing face mask as an alternative to a back mask device for short duration. You don't want to use a back mask a lot, because again, it gives you more aerosolizations, and of course with the risk of transmissions. If intubation is delayed, you have to consider doing a supraglottic airway. Do not stay there and be bagging a patient for a long time, because again, of all the risks, you don't want to expose the rescuers. Again, then make sure that everything is tight. The circuits are tight. You want to avoid any disconnections, minimize any disconnections of circuits in patients with COVID during a code. If the patient is already intubated, don't disconnect the vent. Leave the patient on the vent with a HEPA filter. And again, adjust the vent settings to allow for a synchronous ventilation. You want to consider the following strategies. Increase the FiO2 to 100% or to 1. Change the mode to pressure control ventilation, and then you limit pressure as needed. You want to make sure that you have just enough pressure to generate adequate chest compression. So you want to target a pressure of 6 mL per kilogram of ideal body weight. Don't make sure that the pressure is not too high, because again, some of the equipment can pop with high pressures, or you can form stacking, and you want to avoid that. If a patient is, again, intubated, you want to avoid any unexplained extubation, avoid hyperventilation and any air trapping. You want to adjust the respiratory rate to 1 to 10 minutes for adults, and then you adjust the PEEP to balance lung volumes and venous returns. Again, adjust alarms to prevent alarm fatigue. You don't want the alarms going up continuously. People get fatigued, and then when something really happens, they may not pay close attention. If a patient is already in a prone position, and they do not have an advanced airway in place, you have to place the patient in a supine position in order to be able to continue CPR. If the patient already has an advanced airway in place, then you leave the patient in that prone position. Do not turn the patient unless you're not able to do CPR without turning the patient. But otherwise, just avoid turning the patient so that you don't disconnect the equipment. Place a defibrillator pads in the anterior and posterior position, and I will show you a picture of that. Provide CPR with the patient in the prone position and you place your hands in the standard positions of T7 to T10 vertebral bodies. So if we have a prone patient who, as we said, is already intubated, leave them intubated, do not turn them, and you do your chest compression in here in T7 to T10 positions in their backs, not in the front. And if the patient has not yet been intubated, you turn the patient to a supine position, and then you do you place your parts and do your chest compressions. Now, for these patients, you press who are especially patients who are in a prone position, you place your parts anteriorly and posteriorly so that you can kind of like have your energy flow, as we can see in this diagram. So our last goal of this presentation was to consider resuscitation appropriateness. And this is a very delicate topic. As we said earlier, you want to make sure that you address your goals of care as soon as the patient gets to the hospital. You don't want to wait until the patient is coding. You address those goals of care and you make sure that the patient's loved ones are fully aware of it. Secondly, every healthcare system should institute policies to guide frontline providers on what to do with regards to patients who have COVID-19 and go into cardiac arrest. And when they are instituting these policies, they have to take into account the patient's risk factors to estimate the likelihood of survival. If this patient is is in a poor state of health and has a very low probability to survive, even with an appropriate CPR or ACL or ACS, there is no point for you to do that and for you to go ahead and do chest compressions and expose these rescuers to COVID-19. So again, the hospital needs to make that determination much earlier, and that has to be communicated to the patient's relatives or to the patient, so much so that when it happens, they were already aware of that. So just quickly here, the main things that were added to the ACLS algorithms with regards to codes is, again, for the BLS, is just to make sure that we don our PPEs and we limit the personnel in the room. Those are the main take-home messages. But additionally, also, you want to make sure that you use a back mask device with filter and airtight, and it's the HEPA filter, the high efficiency particulate air filter. You want to use that for patients, for these patients. And then you want to do continuous compression with passive oxygenation using the face mask. You have to really avoid situations where you have to bag the patient for a long period of time. For our ACLS, the main things that changed was, again, limit personnel. Consider if this patient should actually even go into, even have resuscitation based on the criteria that we kind of like mentioned before. And again, this is something that has to be communicated to the patient or to the patient's proxy prior to them even going into a code. So you do this as early as when the patient gets to the hospital. You pause chest compressions to intubate the patients. This is something that is different from the regular algorithm. The algorithm states that we continue chest compressions while we're trying to intubate the patient. If intubation is delayed, then you have to consider getting a supraglottic airway or back mask device with a HEPA filter and tight sealed, as we mentioned earlier. Then connect to ventilator and filter when possible. As soon as you can, make sure that this patient is intubated and connected to a ventilator. That is what they are saying. Don't keep this patient, don't try to intubate, ventilate this patient mechanically for long periods of time. You have to very prompt with placing the patient on the vent. So as soon as the ventilator is ready, please place this patient on the vent. So post-cardiac arrest, you want to make sure that you consult your infection control team practices. Every hospital should have infectious control team practices, which with regards to how to transport this patient to any other location. You don't want to take a patient who maybe is aerosolizing and then go around the entire hospital with these patients and just contaminate the entire hospital. We want to make sure that we avoid those. So if a patient is coding in a unit which is not an intensive care unit and you have to transport the patient to the intensive care unit, please make sure that you're following very closely your local infection control practices. So I would like to conclude by saying that, again, minimum number of core team members and equipment is needed in the room to avoid close communication. You want to clearly define the roles, responsibilities of each core team member and minimize the number of core team members. Use mechanical chest compression devices for patients who have COVID-19 or patients who are under investigation for COVID-19. And then you want to prioritize oxygenation and ventilation strategies with lower aerosolization risk, and always consider resuscitation appropriateness. Thank you very much. And something we want to always remember is that we want to give our patients the best chance of survival without compromising the rescuers. Thank you very much. Any questions?
Thank you, Dr. Joyce. I must say this is a reality, especially if you work in critical care units or in emergency department. This is what we get. Sometimes, most of the times, we don't even know if they are positive or negative or we're in contact with people. And anybody know that if it's a code, everybody runs and everybody do what's needed. But I must say, I did enjoy your schematic thing where people are supposed to stand. And I think, you know, we will also be reminded that there is a way to do things to make sure the rescuers are more better off than putting them at risk the whole time.
Correct.
Any questions that anybody want to ask or any comments?